All right, we could probably get going, but we welcome everyone to our fifth virtual meeting of the series. Tonight we welcome Dr. John Jefferies again, and thank you, Dr. Jefferies, for providing another presentation.
I'm Dawn Laney. I'm a genetic counselor at Emory, and I'm so excited to introduce Dr. Jefferies again to talk to us. You may remember Dr. Jefferies is the J. M. Sullivan Endowed Chair in Cardiovascular Medicine and Chief of Cardiology at the University of Tennessee Health Science Center. It's also the co-director of the UT Methodist Institute for Cardiovascular Science. And as you know, he also has spent lots of good quality time thinking about Fabry disease, doing research and studying what happens, the impact of Fabry disease on the heart. And I'm very excited to see what he's going to share with us today. Dr. Jefferies.
Let me see if I'll try and share my screen here. All right. Can everyone see my screen now? Super, very good. Well, in the interest of time, I'll try and make sure that we, talk through these relatively reasonably quickly, but obviously I'd be available for any sorts of questions or anything else that I can help with later or by email. But I was asked to speak specifically just about testing for the detection of cardiac involvement in Fabry disease. And actually, it's even a little broader than that. It'll be cardiovascular, so actually some of the vascular pathology as well. I won't bore everyone too much with all of this, just to remind everyone that this is one of those deposition sort of based diseases that we see in cardiology, and there are numerous ones. Fabry, fortunately, has garnered a lot more attention recently for a lot of different reasons, but to keep in mind that it is a systemic disease. And so anytime when we speak, you hear me, you hear Dawn, you hear Dr. Hopkins, whomever, remember that it's not just one organ, and these organs don't live in silos. So they all talk to each other, if you will, the heart, the kidneys, the heart, the brain, the heart, the lungs, the heart, the liver, blah, blah, blah. So be mindful that cardiac disease can affect other organ function. And I think that's an important thing just to take away. And you've seen these slides before, I think. The main thing that we're trying to do, honestly, from my perspective, when we talk about genetically triggered diseases, especially if we know someone harbors a mutation, is to look early and to intervene early. And because there do come sorts of edge of the cliff phenomenon where you go so far that you really can't retrieve certain things, whether that's a rhythm disturbance, whether that's heart muscle function, whether that's heart failure. So all these things we would really prefer to catch people when they're sort of beginning to show manifestations of disease, typically in a pre-symptomatic phase. So you have involvement in your heart, for example, but you're not really experiencing symptoms. Can we do something about it? That's typically the best place, at least for now, to intervene. Ultimately, probably prophylactically would be the best, but we're not quite there yet. And we know that heart disease is a big component of what we do with Fabry. And as you all, I'm sure, are aware, that's the leading cause of mortality in Fabry. So it's really an area that we've tried to focus a fair amount on. And, we talk about people having involvement in the heart. Typically, people talk about it in adulthood, but I'm typically the first to challenge that. I don't think that's actually true. I think there are evidence of signs and symptoms before adulthood, but typically it's in a situation where people don't know they're actually looking for Fabry. And if you don't know what you're looking for, sometimes that informs or misinforms the questions and the tests that you pursue. It's just that simple. So I think you'll see these sorts of arrows actually move over time more into the adolescent population. These are some of the things that we see, and these are the things we really try and do surveillance for. So high blood pressure, systemic hypertension is not uncommon, and that may have a variety of different causes. Obviously, kidney disease can lead to high blood pressure, but there are other components to that as well. Your heart can become thickened. This idea of left ventricular hypertrophy When you've heard or read other literature, this may be referred to as hypertrophic cardiomyopathy. In the most classic sense, it really is not hypertrophic cardiomyopathy. It's called a phenocopy is how we refer to it in genetics. But really, I just want you to take away that it's a genetically triggered reason for the heart muscle to be abnormally thick. We can see heart rhythm problems, including unusual rhythms like atrial fibrillation or ventricular tachycardia. And we do know that conduction system disease can be a problem, meaning the ability of electricity to be promoted throughout the heart can be disrupted. We know the valves of the heart can be involved. Remember, there's 4 valves, 2 on the left side, 2 on the right side. Typically, it's the left-sided valves that become involved, which are the aortic valve and the mitral valve. So we pay attention to those, typically with echocardiography. Vasculopathy is just sort of a catch-all term. I'll show you some pictures about things we kind of pay attention to, but it is an important component of all this, meaning that the blood vessels, one, can become dilated, or what's called aneurysmal, but the other piece is that they can actually become dysfunctional, meaning when they're supposed to dilate, they constrict, and when they're supposed to constrict, they dilate. And that's a very complicated problem, but it is something we're starting to see more of. Ischemic heart disease is what you know everybody classically is having a heart attack. And we do know that there is an opportunity for premature heart attacks in folks with Fabry. And then lastly is sudden cardiac death. And this comes back when you have an experience, just an absolute, drop to the ground sort of a thing. That is typically a rhythm problem. There are other things like stroke and whatnot that can do it, but specifically for us, that is typically a rhythm problem, specifically usually ventricular tachycardia or ventricular fibrillation. And this is kind of a nice slide that kind of summates what I just told you, but it gives you a little more granularity. So we know that we have the sphingolipid deposition, which is the underlying sort of pathology for Fabry. And we know, as I said, the cardiomyocyte are just heart muscle cells. We know that they can become big or enlarged. We know that they don't always work well, but we also know that the tissue surrounding those cells can become dense and actually become larger, which leads to a thickening of the heart muscle. And I'll show you some information about that, which we think is pretty interesting. The endothelium is back to what I was telling you about, should constrict, but it balloons up, or it should dilate, but it constricts. That's the problem with the endothelium, or the inside lining of the blood vessels. The rhythm problems we talked about, and we talked a little bit about the valves. So the reason that we care about all this is that this can be a real problem over time. These arrhythmias, as we said, they could lead to sudden death, or they can lead to a lot of complications. So things like atrial fibrillation could lead to stroke. And we already know we have a stroke propensity in Fabry, so that's a double whammy. So those are things we don't want. We know that heart failure can be a big component of this, and you may have heard on the prior lecture, we talked a little bit about heart failure and some of the therapeutics for that. That's a real problem when we talk about Fabry. Heart failure is a really difficult thing to treat, and regardless of the cause. And we invest lots of money and time into trying to do it. But the best way to treat heart failure is actually to avoid it. So that's part of what we're trying to increase awareness about. The ischemia you heard about, and that would be those things where you have a heart attack, we may bring you in, do a balloon, stent, those sorts of things. And then a stroke, and we're trying to figure out the reasoning or the cause behind the stroke. We do know that carotid disease can occur. We know intracerebral deposition can occur. But back to, we also know atrial fibrillation can occur, and that's a big cause of stroke in the general population. And all these things are just really hard to treat. And once you have them, it's really hard to go back, if you will, except for the arrhythmia piece. Sometimes we can mitigate that. The other things are really hard to undo, so we'd like to not have them. So, as I said, it's the leading cause of mortality in Fabry, cardiovascular disease. And these are somewhat old data. We report that 60% of patients have prior signs and symptoms. In my own experience, if I ask enough questions of most Fabry patients, they almost all have had some sort of potential symptoms consistent with Fabry. So once again, it's knowing what you're looking for, right? We know people complain of high blood pressure. We know they complain of swelling. And that's a complex thing in and of itself. So edema is just a fancy word for swelling. But we also know that Fabry disease can have heart failure, so they can be congested because of that. But we also know they can have lymphedema, which is a completely different problem. So it becomes a little more challenging, even at that level, to figure out what it is sometimes. And oftentimes people will have a history of shortness of breath, chest pain, or a murmur. You know, if you think about it, pretty nondescript. I would guarantee everyone on this call has shortness of breath at some point in their life. But were they running a marathon, right? That's the question. And so you have to adjudicate these symptoms once again carefully, I think. For us, like I said, we really want to prevent the disease, and that's all about surveillance, which is kind of what we're talking about now. And once you have these diseases, like I said, if you experience heart failure, if you experience a heart attack, your outcome automatically changes. Your longevity, your trajectory changes unequivocally. So we don't want that to happen. And these are these graphs, once again, when we have first CV events, if you will, pretty old information, a decade old now. Once again, I think it comes back to, you know, limited data set, especially in younger patients when this publication came out, and were we actually looking the right way? And I can tell you confidently, no. So what I'm saying is the next kind of publication such as this, those bars will shift to the left unequivocally. But you can see you have males and females, and oftentimes it's 45 to 55. But when you talk about CV events, what do we really mean? We mean a heart attack, stroke, heart failure, all those things that we don't want to happen. We need to look a little bit earlier, which is what we want to do. So as I said, arrhythmias, you know, are a real significant piece of pathology when we talk about Fabry and cardiovascular disease. And the bradyarrhythmia and tachyarrhythmia just simply means slow rhythm disturbances and fast rhythm disturbances. And they're very different in the treatment modality. So a slow heart rhythm that causes symptoms may be treated with a pacemaker, right? If you have a fast heart rhythm that's potentially life-threatening, we might put in a defibrillator for that. So those are different technologies. But remember, all defibrillators actually can be a pacemaker, but no pacemaker can be a defibrillator. So if you get the defibrillator piece, you get sort of 2 for 1, but it has to be put in for the right reason. And sometimes we'll actually go into the heart with little catheters and try and stimulate unusual heart activity. So people come in and say, you know, doc, I was just walking the dog, and next thing I knew, I was looking up at the sky. I had passed out. People walked by, said I was out completely. We don't really know why. That may be an opportunity for us to say, well, could we go in and potentially provoke potentially lethal heart rhythms? And because we would always assume that's a potentially lethal heart rhythm that was just spontaneously aborted, if you will. So sometimes we'll consider that as well. So this is just a tracing, and you don't have to get too captivated by it. It simply just shows us that the electrical propagation in the heart is abnormal. So this is someone who has that bradyarrhythmia or bradycardia, and they actually have on the left is a normal rhythm. If you can see the arrow, that's a sinus rhythm. But then these next 2 beats are premature ventricular contractions. So that means that instead of coming from the top chambers, the initial beat is coming from the bottom chambers, which is not normal or not what we want physiologically. And this is someone that we would think about putting in a pacemaker. And we also know that, you know, the way that the electricity gets dispersed in the heart is an important thing. So the electrical starts in a thing called the sinus node. It goes down to the thing called the atrioventricular node. And then there are branches that come off of that, sort of like tree branches, that sort of go out with little twigs into the heart muscle. And that's how all the electrical activity gets delivered. Well, sometimes those twigs get disrupted. Sometimes they even get broken. And that's probably because of GL3 deposition, for example. We can measure that on just an EKG. And some of you may have heard that your doctor may have told you that you have a bundle branch block, okay? And that's what this represents here, is that normally that should be less than 110 milliseconds. The QRS is just going from that node down through that tree branching, if you will. But then people that are abnormal, meaning over 110, that suggests they do have a bundle branch block. And this is a Kaplan-Meier curve. Kaplan-Meiers are traditionally used to depict mortality. And you can see that if you have that tree, that tree branching problem, the electrical conduction disease, your mortality is very different than someone who has normal conduction, almost 25% difference at about 4 years. So that's an important thing to know about, because one, it tells us that you have problems with the electrical system, which is probably from Febre. But there's also things that we can do about this to help improvement, such as fancy pacemaking and that sort of business. So just something to keep in mind, that all of you have EKG. Some of these other technologies we're going to talk about, your doctors probably have not heard of and almost guaranteed you're not doing. But this one, I guarantee you are. And this is something that you can look at yourself on my chart or whatever. The other question is, well, how could we figure out if someone is having unusual heart rhythms? The problem is, if you read about a basketball player, soccer player, whomever that passes out or arrests on a court or field or pitch, whatever, the problem is we don't have a monitor on them at the time. So we have no idea what happened, right? No idea. Now, sometimes we can put an AED on and they may still be in that rhythm and we can figure it out. But for the most part, we have no clue. So we try and do surveillance to look for those heart rhythm abnormalities. And sometimes we actually will have a device someone's monitoring while they have an event, but most of the time we're seeing subclinical kind of stuff. So meaning we're seeing short runs of bad heart rhythms, but they go away spontaneously. When they don't go away spontaneously is when you have the cardiac arrest. So what we would typically do, you see up in the left, is a thing called a EKG machine. So it's just that traditional 12 lead with a little pink sheet of paper that you see. But that's only about 3-4 seconds of your life. And so it's not hugely representative of everything. So oftentimes we'll go to the next step, which is a thing called a Halter Monitor, or an event recorder. And you can wear those sometimes for up to 30 days, but you can appreciate they're cumbersome. You have stickers on your chest, can't take a shower with them, blah, blah, blah. And once again, at best, it's only 1 out of 12 months, okay? There are devices and this is an example of one down below that's actually not available anymore in the US, but there are other ones. But this is simply a device that sticks on your chest, and it'll give you about 7 days worth of data collection, and you can wear multiple onesies to do it. But once again, it doesn't give you the entire spectrum of a year. The thing at the bottom is the thing that we've been using a lot more of in my practice, at least for genetically triggered heart disease. And they use this a fair amount in Europe and Fabry specifically. And it's a thing called an implantable loop recorder. This particular one is made by Medtronic. It's called a Link device, but there are other companies that make devices. Boston Scientific makes a device, Abbott makes a device, but this one probably has market share, so you'd see the most of this. And we've used this in a few of our patients. It's typically one of those things where I just can't capture anything on these other modalities, right? But patients are saying, I'm just having these weird feelings and I get dizzy with it and blah, blah, blah. So sometimes we'll do this. And when you do, sometimes you'll find stuff. So this was actually a female that we were treating in her 60s, heart failure, significant hypertrophy of her heart muscle, kept having symptoms. We put one of these recorders in, and this actually captured this unusual heart rhythm, which you can see looks really jagged like teeth. This is a ventricular tachycardia, potentially lethal heart rhythm. So she actually got a defibrillator because of this, and went on to have what we would call appropriate shocks. So meant the device was in, it saw more of this stuff, that it didn't go away, and the device fired and shocked her back into a normal rhythm. And this is all just surveillance, so looking for it. And as you've heard from me countless times, the biggest advocate you have in this world for your disease is you. So tell your providers, let them know that these are things that you're interested in knowing more about, okay? So that's the rhythm piece. The other piece is that all of you have probably experienced or that you've read about is the picture piece, right? So how do we look at the heart, quote unquote? Ideally, we'd look at it under a microscope, but that's not always a pleasant thing to take someone's heart out. So we'd rather leave it in and look in other ways. And this is one way to do it. So we use echo, which is just ultrasound. So just like if you had an ultrasound of your belly or of your pregnancy or whatever, same stuff. And the thing about echo is everywhere in the United States, most places and even underdeveloped countries have access to echocardiography. So it's pretty good. And it's been around a long, long time. The problem is it doesn't tell us, it doesn't really show us specifically about heart muscle per se. And I'm going to show you more about it in a minute. But we've been able to modify traditional ultrasound techniques to give us a little bit more information. So this is kind of, when you look at the slide, it's an old slide, but it really is very much on target. The top one would be someone, let's say, that has that we talked about. So you have a normal heart on the left, then you get damage where you get this kind of blackened area in that sort of tip of the heart. And ultimately what happens is the heart balloons out and those areas don't squeeze very well. And that whole business is called remodeling, okay? And that's a bad thing. And we use medicines to try and reverse it to go back in the other direction. What we typically see though in Fabry is the bottom where the heart muscle becomes thickened. So you can see normal, then the middle frame, it becomes very thickened. And then some of the time it actually will progress on to more of that dilated thing. And basically what it means is that all of that thickened heart muscle gets replaced with scar over time. And that thickness of muscle decreases because it's replaced by scar. So it becomes thin and it doesn't squeeze very well. And so that's what we oftentimes will see. But the middle picture is the characteristic sort of pathognomonic findings that we would see in someone with Fabry. And these are, these are still frame echoes, and I could play them, but it's a lot easier actually for you to see them still. So on the left is a picture of a normal heart, okay? And hopefully you can see my cursor, but this sort of prominent chamber is the left ventricle. That is the pumping chamber. That is the one that we are paying attention to, okay? And you can see here's the middle wall separating the left ventricle from the right ventricle. And this is all the normal wall thickness of a normal heart. You go over here and you can see on the right, you see a much thicker heart muscle. And this is that hypertrophic kind of piece that we were talking about, where the heart muscle is obviously thickened compared to a normal heart. And you can look at the heart on a cross-sectional basis. So if we cut across your chest, the left heart is kind of the donut we're looking at here is a normal heart, but look at an abnormal one. It's pretty obvious, right? And interestingly, these areas, the heart muscle itself doesn't really suffer from squeezing too poorly. The problem is it actually has trouble relaxing. That's the issue. It's called diastolic dysfunction, or what we would call heart failure with preserved ejection fraction. And that's oftentimes what we're battling when we see someone with Fabry. But, you know, I don't want it to get to that point, right? That's not a good thing. So what could we do to avoid that? Well, we could look at the heart when it looks more like it's in a normal stage and try and catch it when it's on its way up to thickening, if you will, to see if it's abnormal in some way. And we can do that with a business called strain imaging. And this is available in a lot of medical centers. We do it almost on everyone who has a history of cancer, for example. So if you've had breast cancer, get toxic to your heart, we use this technology to identify heart involvement early, basically, so we can get on the right kind of therapies. Same paradigm applies for Fabry. And basically what we're talking about is looking at little tiny sections of the heart to see how well they squeeze and relax, squeeze and relax. And that's really all it is. It's called tissue deformation. And this is the way the heart squeezes. You know, people think about it as like lub dub, lub dub. Unfortunately, it's not that simple. the heart actually squeezes in 3 different directions. So it squeezes from top to bottom. That's the longitudinal thing. It actually squeezes, that donut will squeeze inwards, so that's circumferential. And then the normal heart actually has torsion. It's just wringing out a dish rag. That's the torsion or the twist component of function. So there's the 3 ways that the heart squeezes. And we can actually measure that with the ultrasound. And this is what we would do if we were looking at all the different areas of the heart muscle and squeezed them down, basically compressed. This is called a bullseye thing. And the simple thing about this is if it's all red, it's all normal, okay? So this is a normal heart where we've looked at all these little areas of the heart muscle and it all looks great, okay? And you can see this little scale. The more you get to blue, the more abnormal it is, okay? And this is looking, all these little dots represent places that we're looking with every heartbeat to see how well the heart goes in, out. So the heart should thicken when it squeezes and then it relaxes, thickens, relaxes. And so this is that normal one again. And all these little different segments we're tracking on this line. And they should all be superimposed if everything is working correctly. But now let's look at someone with Fabry, okay? You see on the left is the normal, all red, right? On the right, not red. So you see orange and green and yellow and blue. But notice the heart thickness is completely normal, okay? So what I'm saying is that if you had a conventional echo, they would say your echo looks fine, right? It's not thick. Maybe it doesn't relax perfectly, but I don't see anything major. I don't think we need to do anything. Well, if you did this, then you're going to say, cow, it's completely abnormal, right? So those are the things of early detection talk about. Like I say, this isn't like Nobel, you can only get it in Oslo sort of technology. You can get it all over the United States. And it's something you want to ask your providers about. The other thing, if you come to see me, or probably I'm sure in Atlanta, if you go see Bill or any one of those folks, is that we're going to look at a cardiac MRI. And this is kind of the way I describe it is just, you know, most of you are old enough to remember black and white TVs. Echo is kind of a black and white TV with an antenna. MRI is kind of like 4K high definition, you know, ultra pixel stuff, maybe 8K. But it's a little harder to obtain, you know, it takes a little more time, but the information you get is much more valuable. And like I said, that echo, if you've ever watched one, it's just black and white stuff squeezing on a screen. That's what it looks like. And it doesn't tell me about the heart muscle specifically, it just tells me about the squeezing glob, basically. Strain helps a little bit, but it still isn't perfect. We can use MRI to actually look at the heart muscle, which at the end of the day is kind of what we care about. So the advantages of this is that it's really, really reproducible. So if you do it over and over and over, you're going to get the same measurements. Echo has quite a bit of variability, even by time of day. I can image Jerry this morning and this evening, and the measurements will be a little bit different. MRI is not that way. Gives you really precise ability to look at how big the chambers are, how thick the walls are, all that kind of stuff. And most importantly, I think there's a misconception about MRI. There's no radiation, okay? So it's not like getting CAT scans, for example. And we think it's very valuable. And I'll kind of give you some ideas of why. So this is if you look on the left, you can see this big prominent sort of dark area in the middle. That's hypertrophy. So that's septal hypertrophy. And out here is the outside wall of that pumping chamber, which is also thick. If you go to see someone for cardiac MRI, you want to ask for, as long as your kidney function is okay, a thing called contrast or gadolinium contrast. And what we do is we give an IV contrast agent. And essentially what happens is that in a normal heart, this contrast will get sucked up into the heart, but then it gets cleared out immediately. But if you have scar tissue, for example, the contrast will kind of get hung up in those areas and it hangs around. And we can see that on a picture. And that's what these little arrows are depicting, is what's called late gadolinium enhancement. So where it should all be nice and black, like this middle part, you see these white areas in the black, okay? And that represents most likely scar tissue. And scar is a problem, right? SCAR doesn't squeeze, and SCAR is a nidus for those unusual heart rhythms we talked about. So these are important things, especially when we talk about a business like, do you need a defibrillator? This is the kind of test that's going to help us to understand all of that, right? So that's an important sort of surveillance technology, if you will. But what about if we could once again find it earlier, before it becomes thick, before you develop the scar? And what if I could do it without having to give you a contrast agent, which might potentially damage your kidneys? And you can. So most centers now do a thing, well, most academic centers or true Fabry centers would be doing a thing called T1 mapping or native T1 mapping. And what that means is just some pictures before we give the contrast to try and get an idea of what's going on in the heart muscle. And it's a numeric value, so it's quantitative, which makes life a little bit easier. And we know where the cutoffs for abnormal are. And so this is just a typical kind of screenshot of what I see with this T1 imaging. And you can write this down as truly just capital T with the number 1. So if you look on the left, it's normal. And you know, I'm a simpleton, so the colors make it easy for me. So it's all purple, and you can change the colors to whatever you want, but it all looks nice and purple. So that means it's all homogeneous, right? So that's normal. And you can do that by giving the contrast, which is the post-contrast thing, all nice and homogeneous. It's all orange with that one, okay? But let's say you've had a heart and we want to know what's going on. Well, this is with that contrast agent gadolinium, and you see the white where it should be black, okay? But we can verify that very easily using the T1. So meaning we got the same information, but we didn't have to give someone a contrast agent, okay? Same for people that maybe have valve disease, like aortic stenosis. You can see instead of nice and purple, you see purple and orange sort of intermixed with the T1. You can get overwhelming fibrosis where you get even more of that sort of orange interplay. And then something like a cardiomyopathy, like what we're talking about for Fabry. And look how distorted this is, right? So all these numbers are very unusual and abnormal. Like I say, you don't have to be a radiologist, cardiologist to be able to look and, well, it doesn't look like all the same color. And that gives you a lot of information. And the important piece is this is the normal number 1100, and it's different based on the type of scanner and institution. You can see this is 100 milliseconds larger. So that's the quantitative piece that we can look at, right? And this is just some of the things that we can do. And the thing I would call your attention to is that, and this really is kind of the cutting edge for Fabry care currently, is the thing called ECV, which represents extracellular volumes. So we do this a little bit, sort of the guru for MRI and Fabry is Professor Moon. He's in the UK. And he has an active study looking at this stuff currently to see if these abnormalities in this particular value predict outcomes over time. And like I said, the ECV is very simple. Is you have cells in your heart, but they're all kind of held together with a glue or a matrix, if you framing of your house. Well, sometimes framing can expand, and that's a problem. That tells you there's pathology going on. And so that's what this ECV actually tells us. And it's another quantifiable number that we know what it should be, and we know what an increase looks like. And so when we look at it for Fabry, for example, it's very interesting because we've looked at a lot of different conditions. And the takeaway is an important one, is you can very easily document the cardiovascular pathology with this T1, meaning no contrast. But the important thing is that Fabry is the only disease that we know of, the number, instead of going up when something is wrong, it actually goes down, okay? And that's very characteristic of someone with Fabry disease. And so these are some of the things that you can see with an MRI and the differences based on male versus female, control versus Fabry. And these are things that you want to pay attention to if your doctor or provider, whomever is following you for cardiac disease. We want to know how much muscle do you have? So that's called an LV mass. We also want to know how big the chambers are, both when they relax and when they squeeze. And then this cardiac index is basically how much blood are you effectively delivering to your body. These are kind of nice slides, there's always been this sort of misunderstanding, I think, about cardiac disease, in that it was classically thought that maybe your heart has to get thick before you can have heart damage, and that absolutely is not the case. We can see these changes, as you just saw prior, we can see these changes well before the heart becomes thick or before it becomes dysfunctional. And I would argue that's what you want, right? Because if you have no other manifestations and you have that, I think that's an indication for therapy, just as a cardiac standalone. So if nothing else, but probably more importantly, it informs what kind of testing do we need to do moving forward to make sure you're okay. And this is just a little bit more information on that ECV, and I'm sure Jerry and Don will provide you with the slides or information. But as I said, this is kind of the latest and greatest thing, is that it's not just about the cells, it's the environment the cells live in, okay? And this is what your heart looks like if we take out a section of your heart, which is section B. We can actually digest all of the muscle out, basically, truly, with enzymes. And this lattice or framework on the right is what I'm talking about, okay? So this actually expands with a diseased myocardium. And it's actually pretty impressive that as that number goes up, it very clearly predicts mortality in other conditions. So we're trying to see if it actually works for Fabry as well. As I said, you can have vascular disease, is the ischemic strokes that we talked about. But the other thing that we've seen is that you can actually have a dilation of the big tube leaving your heart, which is called the aorta. And that's this thing in the middle here. So this over here is that pumping chamber we're talking about, and this is the aorta. And it can actually become dilated or aneurysmal. The problem with that is that if it becomes too dilated, it actually can get a tear, and that's called a dissection, which we don't want to happen. The good news is that we get a little bit of the pieces of information about how big the tube is by echo. We get lots of information if you actually go for that MRI we talked about. We can see the entire tube, but it is something that we need to pay attention to over time. And finding of dilation of this tube, independent of anything else, warrants medical therapy, and it warrants surveillance. Pay attention. This is another thing that we've kind of noticed, is that not all the heart muscle disease is in Fabry. So we talked a little bit about, thickened heart muscle being the sort of characteristic finding, which is true. But the other thing you can see are actually abnormalities in the development of the heart muscle. So this is called non-compaction. And basically it just means if you look at the heart, you see over here, these little strands that are almost like finger-like processes. That actually represents muscle that is essentially underdeveloped. It's immature heart muscle. And that is something we can see in Fabry. And it actually matters because one typically means that that area of heart muscle doesn't squeeze very well. But the other concern is that actually in these little areas, you can get blood pooling and clot. And when that clot mobilizes, it can go to your brain, or your kidneys, or to your wherever, and cause a stroke. So it's important to know what kind of cardiomyopathy you have in the setting of Fabry as well, because that informs kind of what we do. So kind of to summarize all of that, basically what we want to do is catch people before they start having symptoms, if possible, okay? And we want to know what we can do about it at the earliest point in time, from my perspective. And I think that that's what you're hearing about these technologies, is that there's lots and lots of opportunities out there. And I think, as I've told you, I think our responsibility as providers, as a Fabry community, is to educate everyone about what they need to be looking for. You don't want to develop heart failure. You don't want to develop ventricular tachycardia. The problem is many people are reactionary in medicine. They wait for something to happen. Well, that's no good, because that something to happen could be death. So, we need to be proactive in whatever we can do. And I think that you're seeing all this stuff, and the earlier you catch it, it may mean that maybe you get ERT, maybe you get chaperone therapy, maybe you're a gene therapy candidate, whatever the case may be. But we can also use those traditional cardiovascular therapies as well, which I think is very important into prolonging lifespan. And for us, we're big on doing it at all ages. You know, we do think cardiac pathology can exist pretty early in life. And, you know, some people aren't too aggressive with people as they get older when it comes to cardiac pathology. And I actually don't agree with that either. I think that we should do as much as we can to try and promote quality of life and help people be able to do what they want to do. So that's a lot of information. I guess we're ready for the quiz now, but hopefully that gives you a little bit of a summary of contemporary cardiovascular surveillance for Fabry. And I'd be happy to answer a few questions if anyone stayed awake long enough.
There's definitely some good questions for you. I've got a couple for you. There's some in the chat, some you can see. But why don't we start with this one? If you have a pacemaker, can you still have a cardiac MRI? If not, what should I get?
Good question. If you've had a pacemaker within the last probably 3 to 5 years, the answer is yes. Currently all pacemakers and defibrillators in the US are MRI compatible. Now, older ones, not always the case, but for the most part, you can. You just have, it does require a little bit of extra effort, and it does distort the pictures a little bit. You get some kind of unusual sort of sparks, if you will, coming off in the imagery that make it a little bit difficult to see, but you can still get a lot of information. If you can't do that, we typically would, it depends what we're looking for. If we're looking at the heart, I would typically do an echo with the strain that we talked about and maybe a contrast agent so I can make sure I see the heart really well. If I'm looking at the blood vessels, I would use a CT instead.
Excellent. I tend to have, this is not me, of course, I'm reading them. I tend to have low blood pressure. Is that Fabry related? Anything I can do about it?
Yeah, great question. Not classically. We do see some people that it has nothing to do with Fabry. They're just intolerant of medication sometimes. The one thing we would always wonder about with low blood pressure, well, one is make sure your cardiac function is okay, which we presume it is. But the other thing was back to that vascular dysfunction, right? So there is a phenomenon called autonomic dysfunction or dysautonomia, which we're seeing more commonly in Fabry. And that may be, you know, remember the cause of your blood pressure because your blood vessels dilate out. And, you know, let's say they're supposed to be constricted. You stand up and you should be getting blood flow to your head, but they remain dilated and your blood pressure remains low. That might be a problem. And we can help with those things typically with volume expansion and whatnot. I think it's reasonable to talk to your provider about.
Great, thanks. We've got lots of questions rolling in. This one gives me palpitations. How concerned should someone be if they have Fabry, LVH, random extra beats from the ventricle, as well as episodes of ventricular tachycardia with symptoms, but not completely passing out?
Where is that one, Don? Let me find
Top.
that.
Yeah, it's like the top one.
Okay, gotcha. So random extra as well as episode. How concerned varied. You should be talking to your physician about consideration about an ICD or defibrillator, in my opinion. The things about ventricular tachycardia is what your experience is what's called non-sustained, which are the short bursts that go away. The problem is there may come a time when it's called sustained, and that's when you have a cardiac arrest, and that's when you need the defibrillator. So I would pursue that aggressively.
This is from someone. I am scheduled for a cardiac MRI this Thursday. I had a kidney transplant, and the hospital doesn't know whether or not to give me with or without contrast. They
Great question.
would do it both ways.
Yeah. So you may have heard from other Dr. Maurer or Eric or who that we look at GFRs in people with Fabry. Most places say if your GFR is less than 40, they won't give you contrast. I'm even more concerned about that in the setting of a transplant, right? So that's where I would see if we could do this native T1 that I talked to you about, where you I would say hold off on the MRI and maybe find somewhere that could do it. You know, kidney is better than, I mean, a transplant is a big deal, and we jeopardize those grafts. So I think I would inquire. And if they can't, maybe find an area of that could do this kind of imaging for you.
Is there anything you can learn from that cardiac MRI without contrast, or is it really contrast dependent?
No, it's the T1s. And, the MRI of itself, if it's thick without contrast, we really are using the contrast to look for those focal areas damage. The T1s will tell you if there's myocardial involvement, and I think that's kind of what you want to know. Sometimes we do use the contrast if you want to get an idea of how much scar burden there is. That does help decide sometimes if people need a defibrillator, but unless that is a specific question, I think I would err on caution, especially in the kidney transplant or if you have CKD, like chronic kidney disease.
Let's see. Are there special considerations with Febre in determining whether an ACD is appropriate once VT is detected?
Good question. So we really don't have enough population data to establish risk, like a risk score, if you will, for Fabry. So what we use is a surrogate system from the Hypertrophic Cardiomyopathy population, and you can go on and actually find calculators and do your own score. But those are traditionally based on things like how thick the heart muscle is. So if it's more than 3 centimeters, that's a problem. If you have non-sustained VT, that's a problem. If you pass out for no apparent reason, that's a problem. If there's a family history of sudden cardiac death, that's a problem. Back to the amount of scar tissue, that factors in. And then oftentimes we'll also look at the chamber above it, how big it is, called the left atrial volumes, also do that as well. Just Don, I need a quick answer from the hospital. I'll be right back.
Sure. Yeah, while we're waiting, we can do the secret word and the drawing. So the secret word I'm going to give you for this particular talk is heart. So if you can put heart into the chat, we'll get some more questions with Dr. Jefferies. Oh, yep, we'll get more questions from Dr. Jefferies when he's available. And in the meantime, we'll do our special drawing for a gift card. Nice. Looks like everybody's working hard at that. Good job.
You should have asked him to say I heart
Right.
you.
Heart you. All right, we've got some good questions. Hopefully he'll be able to come back and get some. If not, then he's always very giving with answering questions if you contact him directly. Okay, we got you, Sharon. All right, we'll hang out and we'll do our drawing. We'll get our random report.
I'm working on it.
I know you are.
Brenda is putting finding a number and putting it into a random number generator and pick the winner that way.
Yep.
None of us can cheat.
That's right, no cheating. All right, Dr. Jefferies, you may have had a chance to check out some of the chats. We've got probably.
I did not, I'm sorry. Yeah.
Okay, that's okay. I will, I'll read some to you while we're waiting for our special.
So we have the C3O female bradycardia, is that right?
Yeah, we definitely have one of those. Yeah.
Okay. Interesting question. So True, I don't disagree that the number of ventricular and ectopic beats isn't too big of a deal. The supraventricular, I know more about. It says you have bradycardia. If you actually have symptoms from bradycardia, you may want to inquire, is the indication for a pacemaker. The ectopic, the supraventricular ones, I would want to know what they are. And we talk about supraventricular, it's not typically nomenclature, but that could be atrial fibrillation, which is something we'd want to treat. If supraventricular runs and you're symptomatic with it, then I definitely would pursue that. And oftentimes we would either consider doing a beta blocker or something. Alternatively, even maybe a kit for an ablation. So I think if you have questions, you could always ask a different cardiologist. The people that actually specialize in called electrophysiologists, you could ask one of them as well. But I think if nothing else, it warrants follow-up surveillance, meaning more Holters at a minimum.
Sounds good. We have a question. Hi, my 38-year-old son had a stroke. There was a tiny clot in the pontine. Your last slide indicated the possibility of immature muscle development. Would your average cardiologist or radiologist pick this up? He has an MRI yearly. So this is a question, I think. So
if you're having an MRI of the heart, they should be able to detect it. The problem is, it's really a problem, but defined by strict criteria if someone has non-compaction, and it really isn't quite that dry. So you may look on the MRI report, it may say hypertrabeculations or hypertrabeculations not meeting criteria for non-compaction. That is something that is easily visible on an MRI, and they should be able to look at it. And I think what I would actually want to know more about is if there's atrial fibrillation. So that's where I would do more rhythm monitoring. But it's a great question.
yeah,
For sure.
and I think just to be clear, I'm not sure if she was talking about MRI of the brain or MRI of the heart.
Right. Yeah. If you haven't had an MRI of the heart, then I would. I think it's a very important. Important. Sure.
And then she was asking about statins for stroke prevention, or Plavix and aspirin, which I think is more stroke related.
Yeah, it is. I mean, statins are helpful, obviously, for people who have dyslipidemia. They are thought to have what are called pleiotropic activities, anti-inflammatory and whatnot, but that's sort of a unique question. Plavix and aspirin is really going to be based on what your neurologist suggests for stroke prevention. Whether it's ischemic, thrombotic, hemorrhagic, blah, blah, blah. So,
Yeah, stroke prevention can be tricky, so usually neurologists can help you figure out what kind of stroke it was and what comes next. Here's a question. I have an MRI scheduled after hearing your last talk. Yay. However, I didn't ask my cardiologist about contrast. Should I ask for that or assume I will get it?
I wouldn't assume, unfortunately, anything. Most places will do it with contrast, but I would inquire to make sure that that's going to happen. Most of the times they will, but sometimes it depends on the center where it's being done and these other sorts of things. So I wouldn't just leave it to happenstance. If you're going to go through the trouble of getting an MRI, get as much information as you can.
Sure. Another question. I recently had a loop monitor implanted. Based on your experience, how long will it stay in there? And at the same time, I had a heart ablation and just wanted to share how much better I feel.
Awesome. Well, that's fantastic to hear. So it depends on the generation of device and the maker of the device. But typically it's somewhere between 2 and 5 years. Traditionally it's around 3. As far as how long it stays in, you can take it out whenever you want. But typically we would leave it in until the battery life expires. But I think it's great that you have it after an ablation now that there's no recurrence, which is great. So I'm glad. It's wonderful.
Awesome. Please address calcification of the mitral valve in connection with passing out.
Probably not a lot of correlation, especially if you're old life. We commonly see calcification of the mitral valve. It's just a, it's a tissue that over time develops inflammation and damage, and calcium is just representation of old inflammation typically. Unless there was some, flipping, like a embolic disease from the valve or something, it wouldn't typically cause stroke or anything like that. So I think probably true unrelated from that perspective. But knowing the valve is calcified, they do need to pay attention that you don't develop a thing called mitral stenosis over time, which they can do but that's an important thing to pay attention to. But it's very common to have a thing called MAC as you get older, mitral annular calcification. So it's something to pay attention to.
Thanks. I am 37 and have PVCs and PACs. I also have a slow heart beat, active in the 50s to 60s. When should I be concerned about a pacemaker? My father had to get one in his early 50s and died from a stroke because of AFib this year at 62.
Yeah, I think, oftentimes it's back to that, if your heart rate is slow and you feel it, right? Or if you can't mount an appropriate heart rate response to things like exercise, which can easily be assessed with the treadmill test, for example. But it's back to those monitors, because if you have the slow, then that means you're also subject to pauses or what's called asystole. And so we can see that on those Holter monitors where maybe your heart is beating and then 6 seconds you don't have a heartbeat. That is something that would be important. And the thing that I have to inform my electrophysiologist is that Febre is not like traditional heart disease. Okay, you have a heart attack, that's an insult and it's done. Febre is progressive by definition. So if I see something that is getting worse and worse, I may not always wait for the classic indication for a device because I know what's going to happen. Why would I do that? So, I mean, it's one of those things that you kind of have to be, you have to educate them. It's like, listen, man, if it's this way today, it's only going to be worse in a year, period. So sometimes you have to be a little bit more forceful, I guess, with people. But I would suggest ongoing monitoring. And back to the previous case, it might be a good place for a link or a loop recorder.
Awesome. Here's one. I'm a 57-year-old female with 2 VTs and 3,234 ATs over a 2-week period. Is an ICD inevitable or can be treated with ablation? I had a Zio monitor that showed 86 VTs and a Bardy monitor that showed only 2 VTs. Is this usual to show some drastically different results?
You definitely can. I'm trying to pull up all of that information because that's a lot.
It's second from the bottom, so it should be pretty close to the lowest part.
Oh, yeah. Yeah, so you had, I assume that AT is atrial tachycardia. That's pretty impressive. So the atrial tachycardia can be ablated, and most places about 85% or so success rate. The VTs are a problem. If you think about it, to be a candidate for an ablation, it typically means, unless it's AFib, it needs to be coming from a single spot. It's called unifocal. We go in, freeze it, burn it, whatever. Ventricular tachycardia can come from a lot of different areas. There is one area that can be ablated. It's called right ventricular outflow tract, VT. The rest of them really aren't amenable to ablation. And if about kind of what I taught you this evening, scar is the driver for a lot of that. So what happens with an ablation is we actually create scar. So it actually sometimes is a little bit worse. So VT, I wouldn't say ICD is an absolute, have to. Definitely thinking it's part of the consideration. And, sometimes we'll try and use antiarrhythmic drugs or medications to suppress ventricular tachycardia. It really doesn't work in things like Fabry, and I wouldn't want to put someone's life bet on that particular strategy. So the atrials for sure. Ventricular, might want to learn a little bit more information.
Are calcium scores of any significance, even low compared to normal females?
So calcium scores are that's a little different pathology. That's back to the coronary disease question. A 0 score is a pretty good prognosticator. An abnormal one is a little more murky, if you will. And basically what it means is that there probably is evidence of some sort of plaque in the coronary arteries if you have a calcium score above 0. What you can do if you really want to know the next step is either do some sort of stress testing, or what we do more commonly is a thing called a coronary CT angiogram. So just like you had a CT to look for the calcium, they can actually give you contrast and look at the blood vessels specifically and see if there are narrowing or blockages there. And then if there's a real question, they can do a heart catheterization. So basically anything above 0, it's something you have to be cognizant of. And could it represent something? And the answer is yes, it could.
Wonderful. Thank you for taking the time to answer all of those. I'm excited to report that our winner is Lori Wise, the winner of the drawing. So we'll get a gift card out to you. So good questions, Lori, and you get a gift card too. Yay!
Congratulations, Laurie.
Yeah.
Thank you so much, Dr. Jefferies, for giving us another great technology presentation.
You're very welcome. I enjoyed it. Great question. Very thoughtful stuff. So I'm impressed. I think a lot of your audience knows more than a lot of cardiologists I know. So I'm impressed.
Well, you're helping boost their knowledge, so that's great.
Well, thanks again for the opportunity.
Great. Thanks, everybody.
Thank you, Don,
All right.
and thank you all for participating, and we'll see you next time.
Sure. Thanks, guys. Bye.